Right. Welcome, everybody. I see Amber's join us and Joanna, Abby, Alice, Amy. Lots of people whose names begin with A. Welcome, everybody. Thanks, everybody, for being patient. Jessica will give me a thumbs up when we have everyone admitted that's waiting. Sorry for the delay, everyone, but we've got some great information coming up for you. Good to see you. Hello, Melissa. So Jessica, was that all for the waiting room at this time? Okay, and Jessica will continue to be our admin for this and let some people in, but I'm going to go ahead and welcome you. Thank you for standing by. Sorry for the little delay, technical things, right? I'm going to immediately talk real quickly and introduce our featured speaker. We're very excited to have as sponsors of today's program, Memorial Hermann, and our speaker, Dr. Haley Shaw, and she is in internal medicine with Memorial Hermann. She is educated at Texas A&M University, College of Medicine, residency at the University of Arizona, the Banner Hospital System, and she is board certified in internal medicine. She treats adolescents, adults, and geriatric patients with both chronic and acute conditions. She performs annual physicals. She manages patients with type 2 diabetes, hypertension, and hyperlipidemia. She enjoys seeing her patients' health improve over time. Her goal is to provide compassionate, quality, evidence-based healthcare while being an educator for her patients. And in her spare time, she does webinars with us, but she also likes to spend time cooking and running with her husband and son. So I'm going to turn it over to you now, Dr. Shaw.
Thank you so much, Paige, for that introduction. And can everybody hear me okay? Okay. So I, just like Paige said, I'm an internist for Memorial Hermann Medical Group in Clear Lake, and I really enjoy what I do. I enjoy treating a lot of chronic conditions, along with acute conditions, and I'm really excited to meet everybody in this group and be given this opportunity with the Women in Business Chamber of Commerce. So nice to meet everybody. All right, so I'm going to go ahead and get started with my presentation. All right, so here we go. This is just my information, and we're going to start with the video.
It started out like a totally normal day. Mom! Okay, move objection deadline to the third line after survey. Oh, honey, for when you always use the verb estar. What are you doing down there? Did you finish your breakfast? Ow. Whew. Don't hit your brother. Honey, you have to eat something. Here. Okay, 5 minutes to carpool. Where's my coffee?
You okay, Mom?
Oh, I'm fine. Sandwich orders. What do you want?
Almond butter and jelly.
Spaghetti.
You sure you're okay?
I'm fine, sweetie.
I am so late. Hey, buddy, how you doing? Hey, honey. You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Acai, my favorite. See you guys later.
Wear your shoes. Put your shoes back on, please. Go help your sister. We're going in 3 minutes. Oh, my God, what am I doing? I forgot to cut off the crust. Voila. Shoes on, potty if you need it. Honey, get your sister. Okay, here. You sure? Nobody move. I'm getting a dustpan. Oh.
Mom! I think you're having a heart attack.
Honey, do I look like the type of person who has a heart attack? Just gonna sit down. Totally fine. Don't forget to wear the high socks with the shin guards.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not gonna wait. Whoa. Okay. 9, 1, 1. Hi, sorry to bother you. I think I might be having a little heart attack. Nothing really, just some nausea, tightening of the jaw, dizziness, shortness of breath, muscle pain, achiness, this terrible pressure in my chest. Oh, really? They can be here in how long? 2 minutes. Can you make it 10? I thought I had gas. Turns out I was having a heart attack. Heart disease is the #1 killer of American women. So now I take care of my heart and I tell the women in my life to do the same.
Sounds great, by the way.
That's nice, sweetie, but that's not my heart. That is. Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at goredforwomen.org. It started out like a thing. Here. Okay, 5 minutes to carpool.
Okay, was everybody able to see the video? I hope that was enjoyable. So, okay, so let's talk about chest pain. Is it a heart attack or is it a stroke? Or is it a heart attack or is it heartburn? That's the question. There are various causes of chest pain, and the biggest thing we want to check for is if it's a heart attack or acute coronary syndrome. So cardiac causes include acute coronary syndrome or a heart attack. And signs of a heart attack would be substernal pressure or angina with potential radiation into the neck, jaw, left or right arm, shortness of breath, cold sweats, nausea, lightheadedness. And the symptoms can vary between men and women. Women are much more likely to have shortness of breath, nausea, vomiting, and back or jaw pain in addition to chest pressure. So that's a big difference between men and women. Women tend to not, they do have chest pain, but it may not be as severe or as intense as in men. And so that is something to look out for. Women, it's been shown that women are less likely to call 911 for a potential heart attack than men are. So it is important to take these symptoms seriously and call 911. Other cardiac causes to think about are pericarditis and aortic dissection. Pericarditis is different from a heart attack or acute coronary syndrome in that pericarditis causes inflammation in the tissues that surround the heart. Signs include sharp pain rather than pressure, better with sitting compared with laying flat. Aortic dissection is going to be tearing of the aorta, the major artery that carries blood from the heart to the body. Signs of aortic dissection include abrupt, severe tearing pain in the chest or shoulder region with radiation into the back. Pulmonary causes include pulmonary embolism,
pneumothorax, pneumonia, or pleuritis. Pulmonary embolism is going to be a blockage of a lung artery. Signs include sudden onset sharp pain with breathing in and out. Pneumothorax is going to be air buildup in the lung lining, causing lung collapse, often due to a penetrating chest injury. It's pretty rare. Pneumonia is going to be a lung infection. Signs include shortness of breath, fever, and cough. Pleuritis is going to be inflammation of the lung lining. Signs include shortness of breath, gradual sharp pain with breathing in and out. GI causes include heartburn, esophageal spasm, and pulmonary ulcer disease. GI causes, like heartburn, would be chest pain, but it would be more of a burning pain rather than a pressure. There could also be a sour taste in the mouth, nausea, or abdominal upset. Esophageal spasms are rare, and signs include chest pressure with swallowing. Peptic ulcer disease, signs include epigastric pain radiating to the chest, and then so those are some of the GI causes or gastrointestinal causes. Heartburn, can sometimes be mistaken for a heart attack, vice versa. But if it is something you normally don't experience and it's coming out of the blue, it is important to take it seriously. Psychiatric causes are anxiety or panic attacks. Signs of that would be chest tightness or heart palpitations, shortness of breath, and sweats. What is a heart attack and what should you do? A heart attack is going to be is where your heart muscle needs oxygen to survive. And a heart attack occurs when blood flow that brings the oxygen to the heart is reduced or cut off. The blood flow happens through the coronary arteries, and they can get narrowed with buildup of fat, cholesterol, or substances that together are called plaque. This slow process is known as atherosclerosis. When plaque within a heart artery breaks, a blood clot forms around the plaque, and that blood clot can block the blood flow through the artery to the heart muscle. Then ischemia occurs where the heart muscle dies or gets damaged, hopefully temporarily. And that is called a heart attack or myocardial infarction. And the goal is to relieve that block so that the blood flow is restored and that heart muscle can be saved. And again, if you think you're having a heart attack, of course, call 911 so that you can get that emergency life-saving treatment. So here is a schematic. So the first one is going to be is showing the coronary arteries supplying blood to the heart. And then you have these coronary arteries that can build up the plaque, which is in yellow. And then the plaque can become unstable and rupture. The clotting process called thrombosis starts inside of that artery. Once that plaque ruptures and thrombosis starts, that's when the blockage occurs and the muscle starts to die. And here you can see a complete blockage pretty much in the last schematic. And there is dead muscle tissue here. So there's 3 different types of heart attacks. And the last 2, the non-STEMI and the STEMI, are true heart attacks. Unstable angina can sometimes qualify as a heart attack, but it may not be. So the big differences here are that your coronary with unstable angina, the thrombosis or the blockage in that artery is not totally blocked. Neither is it with the non-STEMI. Now with the STEMI, which is the most serious type of heart attack, you have total blockage. And then with the, in terms of history and what a patient may be experiencing, what a person may be experiencing, unstable angina, you're going to have that chest pain, but it's going to be often short-lived, and it often comes and goes. With the non-STEMI, same thing. It can come and go and it's short-lived. With a STEMI, the chest pain is severe, persistent, and it may not relent. When you look at an EKG, which is those 12 leads that measure the rhythm in your heart, with unstable angina in a non-STEMI, you're going to get some changes where there are certain leads in the EKG where there's ST depressions or T wave changes. In the STEMI, you're going to have ST elevations, and so these are just pictures that the cardiologist or physician, ER doctor can see to determine if somebody's having a heart attack. The troponin levels, which are blood levels, are going to be negative in unstable angina. They will be positive and very positive in an NSTEMI and a STEMI, respectively. So those are all clues that can tell a doctor in the hospital what is going on. So what happens on the way to and at the hospital? So first of all, an immediate EKG and a chest X-ray are performed, and that is going to be either by EMS or in the hospital, and then a troponin blood biomarker and general labs, including a cholesterol panel and a CBC and CMP, are drawn. Telemetry is started, and troponin is drawn. EKG is performed every 4 to 6 hours, at least 3 times. If all of that testing above is negative at the hospital and the concern for an acute coronary syndrome is low to moderate, the patient can often be discharged. If testing is negative, but the concern for acute coronary syndrome is still moderate to high, then a stress test for low-risk patients or cardiac catheterization for high-risk patients should be done during the hospital stay within 72 hours. And a TIMI score can determine that risk. And there are different types of stress tests that can be done. The most common one, which you all probably have heard about, is going to be your exercise stress test, where you run on a treadmill and the physician can see the changes in the leads in terms of rhythm changes or changes in just the way the EKG looks. Or you can do a chemical stress test if a patient cannot really run well, or there's some other issue inhibiting them from getting an exercise test. You can get a chemical stress test, where chemical is given, medicine is given to kind of stress induce the heart to allow to see if the heart can undergo stress and if there is any perfusion defects or signs of heart damage with that stress. And that can be, and that's often done with an imaging of the heart, which is usually the case now. Stress tests are done with imaging, where whether it's an echo or a PET scan with a nuclear medicine test, or even an MRI can be combined with that stress test. Now, if there is concern for acute coronary syndrome or heart attack, medical treatment should be started immediately, and that includes an adult aspirin, a blood thinner like Plavix, an anticoagulant like Lovenox, a beta blocker, which is a blood pressure medicine, and nitrate and oxygen is needed. If you see here, in the low risk category, these are patients who may not be a high risk for a heart attack based on risk factors, based on their age, etc. So if a patient is a low risk, like this diagram shows, you can just, the patient can just get a stress test before discharge or even shortly after discharge if they have close follow-up with their doctor. So either in the hospital or right after leaving the hospital with the cardiologist. And then if that stress test comes back where there's not a lot of sign of heart attack or heart damage, then medical treatment and then further follow-up with the cardiologist to determine if it truly was a heart attack or not can be done. Now, if you were to, but if the stress test was positive, you go to a cardiac cath, which we'll talk about in a second. So let's say a patient was higher risk, meaning, and if you look at here, the TIMI score kind of determines the risk. If they're older, they've got multiple risk factors for heart disease, which includes blood pressure, cholesterol, diabetes, smoking, etc. Or if they have used an aspirin in the last 7 days, if they've had known heart disease in the past, if they've had multiple episodes of chest pain, those are all signs that they're a higher risk patient. And if it's a higher risk patient, then you do want to get that cardiac cath done in the hospital while they're there for the chest pain. And we will talk about what the cardiac cath involves. So again, if testing is positive for an NSTEMI or unstable angina, cardiac cath should be done. If testing is positive for a STEMI, it's important for that cardiac cath to be done within 90 minutes. And I'm sure y'all have heard of this term called 90 minutes door to balloon time. But that is why it's very serious to get to the hospital immediately if you think you're having a heart attack. Because if it is a STEMI, then they say, you know, time is tissue is the phrase where you want to save that heart tissue. And the way to do that is getting a patient to the cath lab within 90 minutes to open up any blockage. So here is what is a cardiac cath. So a cardiac cath is where a wire is threaded through an artery into the through the wrist or groin to the heart, because the arteries that supply the heart are actually connected to the arteries that supply the body, and so you can actually feed a wire into the heart to reach the heart arteries. Dye is released into that wire to take a look at the heart arteries. And if there is a blockage seen, then what is called a balloon and stent procedure can be done, which you all may have heard of, where a ballooning procedure opens up the blockage and then a stent can be placed into the area of the blockage to keep it open. That can relieve the blockage and reestablish perfusion to that heart tissue. And after this procedure, usually patients do have to be on aspirin and a antiplatelet medicine like Plavix for at least a year. And a beta blocker or blood pressure medicine is usually necessary as well. Now, the other alternative to getting a cardiac cath is a bypass surgery. And often what happens here is that a cardiac cath is done, but there are too many blockages, or the blockage is in a major artery, where it is better to get the bypass done rather than the cardiac cath, because the bypass has been shown to have better mortality reduction and better heart disease reduction outcomes in the moving forward. And so bypass is a much more intensive, it's a more intensive surgical procedure where arteries and veins are taken from other parts of the body, often the leg, and used in the heart to bypass that blockage and reroute the blood. And this is done by a vascular surgeon, not a cardiologist, but a vascular surgeon. Again, baby aspirin, statin, and beta blockers are needed after this procedure. So I'm a primary care physician, an internist specifically, and where do I play a role in heart disease? Well, for me, I am often seeing patients before they have a heart attack or before they have a heart condition, and patients have risk factors such as blood pressure, high cholesterol, diabetes, especially type 2, obesity, poor diet, lack of exercise, tobacco use or regular alcohol use. These are all risk factors for heart disease. And the more a patient works to control these risk factors, the more, the better chance they have of not having a significant heart condition or heart attack in the future. So it is important to get your, an annual physical, to check blood work, to check blood pressure, especially as you get older, because the risk as you get older of heart disease goes up. Male gender is a risk factor as well. Family history of heart disease is going to be a risk factor. But a heart attack can happen to anybody. And the more we stay healthy at a baseline, the more we can prevent it from happening. In my clinic, I treat these conditions a lot, and these conditions, there are a lot of medications that can be used to treat these conditions, and a lot of them have been shown to reduce cardiac risk, the newer ones. And so I do make sure to prescribe those medicines if possible, if insurance covers them, etc., to lower the risk. Any questions? Thank you.
Wow, thank you for all that great information, Dr. Shaw. If anyone has questions, you can either wave in the screen or put something in the chat. We have a little bonus surprise for you. We've had donated for today a gift card to Escalante's, and Jessica has put all of your names that are on today in the raffle bin. And one lucky winner who was very patient with us today, but also enjoyed this presentation, is going to win this gift card. All right, Jessica, pull the name.
Sorry, let me unmute. Our winner from Pioneer Bank, Elphys Cottingham.
Okay.
Yay.
Thanks for sticking with us today.
Thank you very much.
Yeah. Thank you, everybody. We also appreciate Sarah Martin with Memorial Hermann for helping us line up today. Does anyone have any parting thoughts? We're going to be really excited to get back to in-person meetings with you all. Couple more months, we definitely want to see the vaccination rates get up, but we will on March 18th gather again on Zoom, April 15th gather again on Zoom, and then in May, our first in-person time back together, we have arranged to use the C-Star base in Galveston because we will still be able to be safely distanced there. So we could, we're going to proceed to meet in person in May. We just may still be widely spaced. And then by June, we're hoping to have you all back at the chamber and then do some more fun stuff. So thank you, everybody. If nobody else has anything else to say, Jessica, anything else? Okay, then we will be adjourned. We appreciate y'all.
Thank you. It was nice meeting all of y'all.
Same here. Thank you, Dr.
Dr. Shaw.
Bye.
Bye-bye.